Good evening, friends. Welcome to the Tuesday master classes. This has been for almost last half a year since all our students been getting benefited, and we all got those what a kind of gratifying appreciation across the India. And I thank all the teachers and seasoned faculty who actually participated and helped us. Today, we have two senior faculty with us, Dr. Ramesh Venkatraman, sir, who has been a senior consultant in the intensive care medicine in Chennai Apollo. Sir, we are feeling and honored to be here with us, sir. Dr. Ramesh Venkatraman, sir. Welcome you on the board, sir.
Thank you. Thank you, Venkatraman. It's a good endeavor, and I think it's very useful for trainees, and I'm happy to be part of it. Thank you so much.
Thank you, sir. The other faculty is Dr. Ramesh M. Sethi, who has been a lead consultant in the Department of Critical Care Medicine, White. We welcome Dr. Rajesh M. Sethi, who has been academically on the forefront and being a honored teacher in the part of this South. We welcome Dr. Rajesh.
Thank you, Dr. Venkatraman. Pleasure to be part of this program.
So we have two young, maybe budding intensive care specialists who will be appearing their exam in coming practical session. Dr. Mohan, who has been a part of our team earlier in the before his DNB training. Both of them, Dr. Sivanves and
Yes,
Dr. Mohan, both are a part of Manipal Hospital. So we welcome both of you. It's over to you, Dr. Ramesh sir and Dr. Rajesh sir. Thank you. So one of you can present so that both of them will take forward.
Yeah, you can start with the presentation, I think. Is that okay, Dr. Ramesh?
Perfect. Let's go with it.
Thank you.
Let's start it.
Sir, is my PPT visible, sir?
Yes.
Yeah, can you just make it full screen? Yeah, better. Thank you.
So I started presenting myself. I'm Dr. Mohan. Coming to my case, my patient, 26-year-old lady, was admitted from OPD to wards on 24th of June with complaints of lower abdominal pain from 2 weeks and perineal discharge from 3 years. History of presenting illness: she had this lower abdominal pain, intermittent, it was intermittent spasmodic, and it resolved spontaneously. The perineal discharge was seropulent, associated with fever intermittently. There was no history of bleeding per rectum, vomitings, or constipation. MRI pelvis was done in the OPD. She was diagnosed to have a complex rectovaginal cutaneous fistula with mild diffuse rectal wall thickening. For the same surgical repair, she was admitted to the wards. Coming to past history, she underwent many complex surgeries in the last 5 years. Actually, she's a known case of androgen insensitivity syndrome. In 2015, she was admitted for repair of abnormal external genitalia, which was present since birth. She underwent bilateral gonadectomy with McIndoe's vaginoplasty. In 2016, she was admitted with rectovaginal fistula, which was a late complication of the above procedure. Laparoscopic defunctioning and sigmoid colostomy was done with repair of rectovaginal fistula, and raciloplasty was done. In 2017, she again was admitted with similar complaints of rectovaginal fistula. Laparotomy was done with intestinal vaginoplasty with reversal of colostomy, and a new loop ileostomy was done in 2017. In 2017, I'm sorry, sir.
No, we didn't say anything. There's some echo, I think. We are not saying anything. Right now, we haven't asked him.
Okay, sir. Loop ileostomy closure was done in the same year. In 2018, she was again admitted with perineal sinus and discharges. And this perineal discharge, she was diagnosed to have rectovaginal fistula. She underwent surgical repair of sinuses.
Dr. Mohan.
Yes, sir.
A small suggestion. Going forward, don't say known case. Just say known patient with. Because all of you take international exams, I think it's very common in India to say known case of diabetes, known case of hypertension. It's kind of insensitive. So just as a practice, avoid calling patients as cases, because when you take international exams, that would be something that they look at. So just a suggestion for you in terms of presenting going forward for you and the future presenters, whoever is in the audience. So try to avoid using the word case. It's just my personal bias. I wouldn't like to be called a case.
Sorry, sir.
My job is also to polish your presentation. So I just thought I'll make my point here.
It's a known patient of androgen insensitivity
Yeah.
syndrome.
Great. You don't have to read it again. Just a suggestion. That's all. You can go to the next slide. Thank you.
Coming to drug history and family history, nothing was significant. Personal history, she had no known allergies. Bowel and bladder habits were regular. She was non-smoker and non-alcoholic. General examination, pallor was present. Temperature was 97 degrees Fahrenheit. Heart rate 78 per minute. BP of 110/60. Respiratory rate of 16 and saturation of 97. Systemic examination, abdomen was soft and distended. There was no abnormality detected in CVS respiratory or CNS. She was admitted to wards with a diagnosis of complex rectovaginal fistula repair. She was examined under anesthesia and draining set-on placement was done on the same day. Post-op day 1, soft diet was initiated. Antibiotics started were ofloxacin, onidazole. Analgesics were paracetamol and ketorolac. Post-op day 1 to day 10, fistula care was continued. Antibiotics.
Admission labs were all okay?
Sir, yes, sir. Admission labs, nothing significant was there, sir.
No significant abnormalities. Okay.
Yes, sir.
Why she stayed for 10 days post-op?
Sir, this fistula drainage continued to happen, sir.
Okay.
They examined it under anesthesia and a stent-like thing set-on was placed, but still that drainage continued to happen.
Okay, sure, fine.
So this fistula care, antibiotics, nutrition, and pain management was continued. On day 11, she complained of fever. The temperature was around 101. It was associated with pain in the perineum. On examination, there was a stool in the neovaginal conduit. MRI pelvis was repeated. It showed the same thing, complex rectovaginocutaneous fistula as before with surgically placed set-on. Increase in rectal wall thickening was noted in the sigmoid and descending colon with surrounding fat standing. And she was taken for a laparotomy with the posterior vaginal wall conduit repair and diversion loop ileostomy. Intra-op was uneventful. Day 13, Metcall was initiated for tachycardia, tachypnea, and hypotension, heart rate of 144, respiratory rate of 32, and BP of 80/50. She was started on IV fluids and was immediately transferred to ICU. In the ICU, history was confirmed. General examination, she was drowsy, pallor was present, temperature was 95, heart rate was 148, regular, respiratory rate of 36, BP of 80/50, saturation was not recordable, and GRBS of 112 milligrams per deciliter. Perineal examination showed mucopurulent discharge in the neovaginal conduit. Abdominal drain was mucopurulent, around 50 ml was noted. Ileostomy bag was around 75 ml output was noted. Immediate general examination, airway, she was intubated in view of severe hemodynamic instability. Breathing wise, she was supported with ST control, volume control ventilation, FiO2 of 0.4, tidal volume of 360, PEEP of 6 centimeters, IE ratio of 1:2, and respiratory rate of 26. P plateau was noted to be 24 centimeters. Circulation wise, the cold peripheries were present. Heart rate was 148. Peripheral pulse was feeble and all pulses were felt. Capillary refill time was 5 seconds. Lactate of 4.1. BP was noted to be 92/60, MAP of 68. She was on triple pressors. She was E4, B5, E3, B5, M6. Pupils were symmetrical reacting to light. No focal deficits were noted.
So what was her body weight? How did you get her body weight? Or is it just a guesstimate at this point?
Sir, it was an estimate only, sir. We did not get a body weight. CVS S1, S2 were heard. ECG was sinus tachycardia. No abnormality was detected. Good LV function. EF was 54. Right heart function was also normal. TAPSE of 18 millimeters. No diastolic dysfunction. IVC was 1.3 and more than 50% collapsible on inspiration. Respiratory wise, bilateral air entry was equal. Normal visceral breath sounds were present. Ultrasound test revealed bilateral lung slide was present with A profile. So this is the presentation X-ray after intubation.
Can you just summarize up to this point, in a few sentences?
Yes, sir. 26-year-old lady.
At this point in time.
The 26-year-old lady admitted for a complex rectovaginal fistula underwent repair of the fistula, developed early complication of worsening sepsis. For the same thing, she was transferred to ICU.
So what is the likely diagnosis at this point in time, you think, for ICU admission?
Sir, sepsis, sir, I would think of sepsis as of now.
What evidence you have in the whatever information you have given so far?
Sir, clinically, she was having continuous discharge from the perineal sinuses, which it was mucopurulent. She was spiking fevers. She was tachycardic. Hypotension was present. And coming to initial examination, circulation-wise, she was tachycardic. Pulse was feeble. Peripheries were cold. Capillary refill time was high. So, sir, I would like to modify it. It's septic shock, sir. She was on 3 pressors. As of now, my diagnosis would be perineal sepsis, secondary to complex rectovaginal fistula with septic shock.
So, Dr. Mohan, do you think this is a high cardiac output state that you're describing or a low cardiac output state that you're describing?
Sir, I would think it as a high cardiac output state only, sir.
No, but you said your capillary refill was prolonged. You said that she was cold, clammy. You said she was drowsy. I don't know the urine output. She's tachycardic, right? And if I remember, the blood pressure was 90/50 or 80/50, right? So pulse
Yes,
is narrow. So does all that suggest a high cardiac output state or a low cardiac output state? I mean, just looking at the numbers.
So lactates were high.
No, we have not even gone to the lactate yet, right? We've just gone through the clinical exam. Can you go to the previous slide, please?
Yes, sir.
There you go. Cold peripheries. Peripheral pulse is feeble, which means the stroke volume or the pulse pressure is a surrogate for your stroke volume, right? Which means your stroke volume is low. Capillary refill time is prolonged. That is a lactate. Sorry, I missed it. So lactate is elevated, and all these findings together, do you think it's a low cardiac output state or a high cardiac output state at this point of your clinical examination?
Sir, I would think it as a high cardiac output state only, sir.
Okay.
What do you expect, in a high cardiac output state?
Sir, I would normally expect peripheries to be warm, sir, in a high cardiac output state. But I'm thinking
Diastolic blood pressure?
diastolic blood pressure would be, pulse pressure would be narrow, sir. Diastolic pressure would be normal or less, sir.
You also said she's drowsy, right? One of the reasons you intubated her was because she's drowsy. Your original med call was, when you go to the previous slide, when you received in the ICU, she was drowsy. Go to the previous slide, please.
Yes, sir. She was E3 V5M6, sir.
Drowsy, pallor, tachycardia, narrow pulse pressure, prolonged capillary refill, increased lactate to 4, correct?
Yes, sir.
Okay. You still think it's a high cardiac output state?
Sir, I would think it as a high cardiac output state only.
Why?
Because heart rate was very high. And sir, EF was, LV function was normal. I would think cardiac output would be.
Talking based on clinical examination.
Clinical examination, it could be peripheral perfusion abnormalities I could think about, sir. That's why looking at the echo, I thought it as a high cardiac state, sir.
So can you have a low cardiac output state with a normal ejection fraction?
Yes, sir. Yes, sir. If bradycardia is there, there can be, sir.
Or extreme tachycardia, right?
Yes, sir.
Your heart rate is 148. What happens to your diastolic time?
Diastolic time will reduce, sir.
So you can have diastolic dysfunction, right? Your EF can still be normal. There is already decreased diastolic time. And if there's a diastolic dysfunction, the cardiac output can still be low, right?
Yes, sir.
So heart rate 148 could be a compensatory mechanism for a low stroke volume, correct?
Yes, sir.
So based on this, sepsis, you said, is there any other alternative diagnosis you would think of based on this clinical picture? Forget the echo. We're still looking at the clinical picture. Let's take one step at a time. Is there any other alternative diagnosis?
Looking at tachycardia and
to be a low cardiac output state, correct?
Yes. Looking at tachycardia and hypotension, I would think about other causes of shock like pulmonary embolism or a septic cardiomyopathy. Or hemorrhagic shock, she was post-op day 2.
So at this point of time, clinically, if you ask my examination findings, go to the next slide also. Whatever findings we talked about, right? Cold peripheries, high heart rate, feeble pulses, narrow pulse pressure, prolonged capillary refill, increased lactate with triple vasopressors tell me that's most likely a low cardiac output state, correct? Okay. So one, it could be PE. Can sepsis have a low cardiac output state? Can sepsis have a low cardiac output?
Yes, sir. It can have a low cardiac output state. I mean, it can have a low cardiac output, sir.
When?
So when there is when there is extreme tachycardia or diastolic dysfunction or systolic dysfunction secondary to septic cardiomyopathy.
What is the commonest cause of septic shock with low cardiac output? You think?
Commonest cause, diastolic dysfunction, I would think, sir. Reduced filling time.
Usually it's under-resuscitated sepsis, right? You have not even resuscitated the patient given enough volume, right? If they are profoundly hypovolemic, that's what the original EGDT study showed, right? In Detroit, when people came, their SCVO2 was low, and they resuscitated, it went up, right? They're
yes, sir.
Extremely under-resuscitated. That's not commonly seen in rest of the world. But if there is a very profound under-resuscitation, you will see exactly these features. They are not warm, they are cold and clammy, they have narrow pulse pressure, they have tachycardia, they have prolonged capillary refill, they have increased lactate. As you resuscitate them, you will notice that the pulse pressure widens. So the first thing could be under-resuscitated sepsis, considering a history, complex surgeries, persistent drainage through the drain for the last 10 days. My first bet would still be sepsis, but with a low cardiac output state, probably under-resuscitated sepsis. That would be number one. Number two, septic shock can also cause low cardiac output by the mechanisms you said, right? That would be a systolic dysfunction, diastolic dysfunction, right ventricular dysfunction, or a combination of any of those can happen, right? Other alternate diagnosis of low cardiac output in this patient is one, you said pulmonary embolism. Very fair, right? Patient has been in the hospital for 11 days. I'm not sure what anticoagulation was given considering a complex surgery. So it could be a pulmonary embolism. Three, could be a hemorrhage, like you said. Is there any obvious bleeding internally, externally, pseudoaneurysms from some chronic abscess sitting in there? I don't know. So it could just be a hypovolemic shock at this point of time, correct? So all this differential should be there. And now you're going to be adding on to your examination with an echocardiogram. So before you do an echo, you should have a clinical diagnosis so that you know exactly what you're looking for.
Thank you, sir.
Okay, yeah, please go ahead.
Respiratory wise, bilateral air entry was equal. Normal visceral breath sounds were sound as heard. Ultrasound chest, bilateral lung slide was present with A profile. So this was the X-ray.
No, just go back to the echo now. Now with the echo, we talked about 3 or 4 differential diagnoses, right?
Yes, sir.
Okay, so can you tell me which ones you have ruled in and ruled out based on this echo?
Sir, I could still think of diastolic dysfunction since the filling time was low.
But in this echo findings, what is the number one diagnosis you would give?
So I would give septic shock, sir.
Septic shock, and the reason for low cardiac output?
Low cardiac sepsis, sir. Under-resuscitated sepsis.
Under-resuscitated sepsis, correct. IVC is narrow, 50% collapsible. According to the echo, there is no diastolic dysfunction, even with the heart rate of 148, according to them. EF is, if at all anything, it's normal, right? So clearly looks like under-resuscitated sepsis to be the first diagnosis. No RA-RV dilatation. Is it like 100% sensitive and specific for a PE? Can I rule out a PE based on no RA-RV dilatation on echo?
Sir, I would yes, sir. RA-RV dilatation is present, usually present in PE. I would look into more into RV dysfunction, sir.
It's not there. So can you rule out PE?
So PE can be present like without RV dysfunction, sir. There can be subsegmental PE without real RV dysfunction. So I would like to do CTPA, sir, if I want to rule out PE. It can have a normal RV and RV function.
Do you think CTPA is required in this case at this particular time?
No, sir, I wouldn't take her for PE, sir. Because PE causing shock, definitely RRV dilatation would be present with RV dysfunction. So at this point of time, I wouldn't like to take her for CTPA.
Would it change management, you think, CTPA in this particular case?
Not really, sir. No, sir.
Why it wouldn't change?
So usually, PE causing hemodynamic instability usually has RV dysfunction and RRV dilatation, sir.
So it's unlikely.
Yeah, I feel it's more unlikely to be PE, sir.
So echo findings are seen only in 25-30% of patients with PEs, right? But if somebody's on triple vasopressors with a PE, most likely you're going to see some RARV dysfunction. So this doesn't look like a major PE. PE is not the main mechanism for shock here. Considering what you have told me so far, it looks like an under-resuscitated sepsis, correct?
Yes, sir.
Okay. Keep going, please.
This is the X-ray, sir. Post intubation.
Can you please comment on whatever strikes your eye as probably not normal in this X-ray?
Right, is it air under the right diaphragm?
Optimize better.
Air under right diaphragm is there, sir. She's post-op day 2.
Okay.
I'm sorry. And other thing, I feel like ET tube is little above, sir, above, a little above the carena. Like 2-3 centimeters above the carena.
Okay.
And that's what these are the positive findings I could find.
Central line position you're happy with? Where would you like your central line tip to be? Right IJ, central line tip. Where do you think on the X-ray do you think is an ideal position?
Sir, it should be just below the carena, sir.
So it's the right atrium SVC junction, right? It's too far. Right ventricle, right? Okay. Somebody who's tachycardic, there's a catheter sitting there, sympathetic state, she could go into some arrhythmia. So it may be worthwhile pulling it back to the SVC right atrial junction. Okay.
Okay, sir.
NG position seems to be okay, right? In the stomach.
Yes, sir. Yes, sir.
Yeah. Please continue.
Abdomen wise, abdomen soft distended. She's anuric. ABG high gap metabolic status was present. CNS wise, she was E3, V5, M6 before intubation. Pupils were symmetrical reacting to light. No focal deficits were noted. So these were the initial labs on coming to ICU. Her hemoglobin was 7.6, TLC of 51,000, platelets 3.5 lakhs, PT of 32 and INR of 2.6, APTT 48.5, bun creatinine of 1.02, LFT no abnormality was detected. I'm sorry, sir. pH on arrival, pH was 7.2. PO2 was 120, bicarb was 13, anion gap was present, it was around 19, lactates were 10.4 and base deficit of -15.
So what will be your diagnosis now?
So my diagnosis would be perineal sepsis, secondary to complex rectovaginal fistula with septic shock with AKI with severe metabolic stenosis with coagulopathy, sir. INR is 2.6.
And can you comment on the ABG, please?
ABG, ABG, she is having high anion gap metabolic acidosis. Oxygenation wise, oxygenation is adequate, like PF ratios of 300. Anion gap is 19, sir. It's a high anion gap metabolic acidosis. Lactates are with hyperlactatemia 10.4.
Okay. How much is the anion gap?
19, sir.
19. And is there any compensation?
This is 1.52 by 17.
That comes to around 23. No, I'm doing, maybe you didn't include the potassium. Okay, fine. Okay, so 19 is okay. Yeah.
Sir, compensation is 1.5 into by 20 plus 8, 28. Sir, I would say it is not compensated, sir.
Yes.
So
Fine.
this ABG is done post intubation or pre intubation?
This was post intubation, sir. FL2 of 0.4, sir.
Okay, sorry, yeah.
Fine. Please go ahead.
Yeah, go ahead, please.
She was intubated in view of severe hemodynamic instability. 1.5 liters crystalloids were infused. She was started on vasopressors concomitantly. blood peritoneal fluid and urine cultures were sent. Antibiotics, meropenem, colistin, vanc, and indolefungan were started. Hydrocortisone was given. She was started on CRRT. She was kept NBM. Maintenance IV fluids were continued. RL of 100 ml per hour. Surgical gastro has reviewed and asked to continue the same management.
Can I ask you a question? Go back to the previous slide. Can you just give me the rationale for the antibiotic regime? What bugs are you trying to cover with each of the antibiotics? I mean, you're starting empiric therapy in this patient who's had multiple surgeries. So could you just give me a rationale for the antibiotics picked? Do you justify these antibiotics? Do you agree, disagree?
Yes, sir. Antibiotics, according to our hospital antibiogram, she's already been 12 to 13 days in our hospital, sir. We were predominantly thinking of hospital-acquired sepsis, and a source is probably abdomen and perineum. So most common bug in our hospital and bacteria in our hospital is Klebsiella, sir. So we have it's a MDR Klebsiella. So we have started empirically on merocolistin, sir.
Okay. So my question to you is does meropenem add anything to the colistin in your hospital?
Sir?
Does meropenem add anything to your colistin? Because you said MDR Klebsiella, fine, fair enough. Colistin should cover it. Does meropenem add anything to the colistin for MDR Klebsiella, or are you thinking of any other bugs that meropenem would cover which colistin would not cover in this situation? Other bugs that meropenem can cover that colistin would not cover?
Would be Acinetobacter, sir. No. I'm sorry, sir. Maybe Pseudomonas, maybe, sir. But perineal abdominal, very unlikely source. Sir, I'm covering because the patient is hemodynamically unstable. We are giving multi-drug therapy, sir.
No, I agree with you, Dr. Mohan, but you should be targeting some bug, right? So my question is, does meropenem target any bug that colistin does not cover? Colistin should cover your MDR, Klebsiella, E. coli, and Pseudomonas, correct?
Yes, sir. Yes, sir.
So does meropenem cover any bug that colistin does not cover in your ICU?
Yes, sir. Sometimes protease will not cover colistin.
So there are a few bugs that are intrinsically resistant to colistin, right?
Yes, sir.
Yes, sir.
So one is protease. Any other bugs?
Burkholderia.
Burkholderia. Anything else?
Pseudomil.
Actually, gram positive will not cover. Enterococcus.
No, we're talking about gram negatives. Right?
Yes, sir.
Vancomycin, so we're not going. Okay, Serratia, Proteus, Burkholderia, Stenotrophomonas, right? So all those things would not be covered, but do you expect them in abdominal sepsis?
Sir, I would expect protease in urinary tract infection, sir. And
okay, all right.
Sir, Burkholderia can also happen in abdominal sepsis.
Is there a better drug that has been usually recommended for abdominal sepsis with better penetration in the tissue?
Tigecycline is a better drug, sir.
That would have been a better choice, right? Colistin with tigecycline, correct?
Yes.
Most of the bugs, right? Fair enough. No, I just wanted your rationale on these antibiotics. That's all. So anytime you prescribe an antibiotic, you need to know what source, what bugs, and what drug you're picking for each of the bugs. No, you can't just shotgun say, I'm just going to give these 4 and hope that I cover everything. So you have to be very specific in terms of what bugs you're covering. And you can vary from ICU to ICU, I agree. So you can say in my ICU, in the exam also, you can say in my ICU, these are the common bugs. So I'm going to cover these bugs. This is the likely source. These are the common bugs in my ICU, and that's the reason I'm using these antibiotics.
Okay, sir.
Okay. So second thing for you is colistin. In this patient is anuric with a creatinine of 1. Do you agree with that, guys?
Sir, initial creatinine was 1. Anuric, I would take her creatinine clearance as less than 2 only, less than 20 only. So I would give her a loading dose, and according to the creatinine clearance, I would start her on like a 3 million units OD, sir.
Oh, is there an alternative choice for colistin which may be less nephrotoxic that you know of?
Polymyxin B I could give, sir, but we were thinking of urinary tract infection also.
So for urinary tract you gave colistin, okay, because it's a rectovaginal.
Rectovaginal.
Okay, fine, fair enough. Okay, keep going.
vancomycin and indolafungin were started. So vancomycin, we have started thinking of, covering cutaneous commensals only, sir. Thinking of staph and all. Staph and indolafungin, since the patient has come in shock, we have started empirical on echinocandin, sir.
Okay, fair enough. Yeah.
Hydrocortisone was given.
I would worry more about enterococcus than staph or anything at this scenario. She's got a rectovaginal fistula, so more likely it's going to be enterococcus than staph, right? So vancomycin would be for enterococcus.
Yes, sir. I was thinking of enterococcus.
Elafungin, I agree, as an empiric therapy.
Hydrocort was given, started on CRRT. She was kept NVM, maintenance fluids were continued. So
what is the evidence, Dr. Mohan? What is the evidence for hydrocortisone in this situation?
Sir, she is on triple pressors.
Okay.
So we are thinking of septic shock.
Okay.
So evidence says that persistent shock, noradrenal requirement of more than 0.25 micrograms per kg per minute for more than 4 hours. They ask us to, surviving sepsis guidelines recommends to give hydrocortisone, sir.
It is based on these studies? Which
yes,
studies?
sir. Anani.
Approaches and cortical studies.
Corticus.
Okay, and what did those studies show?
So they have shown to reduce.
Which study?
They are not shown to reduce any mortality, but shown to reduce the ventilator-free days, sir.
Are you sure?
Those
Rationale study. Which study you are talking about?
Sir, Anani trial was a positive study, sir.
Okay.
And the latest studies, Corticus and
Adrenal.
Okay. They have not shown any mortality benefit.
So what was the major difference between the Anand study and the other two studies? Was there anything done differently in the first study compared to the other two studies? And what was the outcome in the Anand study and in the Corticus and Adrenal study? What about other candidate? Shivansh, isn't it?
Yes, sir. Yes, sir. Sir, corticus and adrenal study, it will decrease the vasopressor requirements, sir, along with so Anana study, it conducted in early ARDS patients requiring steroids given, sir. Early ARDS group of patients.
I think you're getting confused actually. That was ARDS study is a different one. There was a study done on septic shock patients as well, but they used two medications. Yeah, whereas
yes, sir. Hydrocortisone was added along with hydrocortisone in Anani study.
Yes.
But in the other studies, only hydrocort was given.
Yeah.
And in the initial study, I think ACTH stimulation was done, sir, in Anani.
Okay.
If you're going to go for exam, you need to know the three common steroid studies, no? And then there is a very nice review in bottom line. So you can go and check out bottom line. They have summarized the literature for you very well. So just go and check it out. I think you should know the steroids in septic shock trial. And what is the outcome? Now, Dr. Rajesh asked you, what outcome did they actually? So one Anand study showed mortality benefit. Others two studies, what did they show?
So they showed like reduced the requirement of RRT.
Hello?
So they basically showed that duration of vasopressor is shorter. That's all. You're able to withdraw vasopressor shorter by a day. On an average 24 hours, you're able to withdraw vasopressors. That's what all the other studies said. This is something that I think you need to, all of you exam going students should know. The steroids and septic shock is something you're bound to be asked somewhere by some examiner. So it's worthwhile investing your time. And like I said, bottom line is one place where they had a very nice summary. I remember reading about a year ago when Adrenal was published. Keep going.
From day 2 to day 7, shock
Sir, report before. Sorry, I missed it.
Sir, actually it was the following slide.
Okay.
Just popped up, sir. Shocked, day 2 to 7, shock resolved over the next 4 days. NG feeds were initiated on day 3. Vasopressors were weaned off by day 4. AKI improved. CRT sessions were stopped by day 4. Blood cultures revealed that Candida tropicalis sensitive to azoles. Antifungals were changed to fluconazole. Continued on mirocolistin. Vanc was stopped. Weaning trials were started on day 4, but remained unsuccessful over the next 2 days due to severe neuromuscular weakness. MRC score was 12/60. CIPN was suspected and she was continued on controlled mechanical ventilation. This was the culture, sir. Candida tropicalis, which is susceptible to all azoles, fluconazole and voriconazole. On day 8, she had abdominal distension and feed intolerance. Feeds were withheld. She again developed new onset hypoxia and shock. NORAD was started. The settings were FiO2 of 0.5, tidal volume of 350, PEEP of 10, respiratory rate of 28, I ratio of 1:2, and P-plat of 28. In view of new onset hypoxia.
One question.
Yes,
in
sir.
this patient, can P-plat be affected by, what are the factors that affect P-plat in this patient?
So it could be her stiff lungs, probably secondary to pneumonia or ARDS. Or it could be she is also having abdominal surgery previously, recently done, sir. That stiff abdomen can also, poor abdominal compliance can also increase the P-plat.
Do you have any method to correct the P-plat for abdominal pressure?
Sir, we can monitor transpulmonary pressure, sir, with the esophageal catheter.
Esophageal catheter. Okay. Anything practical I can do in my bedside? I don't have an esophageal catheter. Do you have one in your ICU? No. Okay. So I have a P-plat that is borderline, say 28, 32, whatever it is. And I am worried about this patient's abdominal pressure being slightly, his abdomen is distended. So is there any way how much plateau pressure could be related to the abdominal pressure?
I would check the intra-abdominal pressure, sir.
Sir?
And
so there is one study that I've actually said that you can use 50% of the intra-abdominal pressure as a correction factor. The intra-abdominal pressure is 10. 5 of this plateau pressure could be related to the abdomen. That's just a rough rule. It may not be accurate, but you need to understand that your traditional P-plat may not be, if you use a traditional P-plat of 28 or less, you may actually be causing a lot of atelectasis in this patient because there is a lot of pressure in the abdomen. So you need to correct it for the abdominal pressure before you interpret your P-plat in these kinds of patients. Okay. So if you think there is significant abdominal tightness, measure an abdominal pressure and correct it for your P-plat.
endotracheal and blood cultures were sent. Fluconazole was stopped and escalated to anidulafungin, considering sepsis. Septic shock. Central lines were revised. She continued to remain hypoxic despite deep sedation and muscle relaxation. Prone ventilation was initiated and.
Just 1 second. You didn't. You said 50% FiO2, 10 of PEEP, and after that,
no, sir, actually,
paralysis, sedation, and proning.
Sir, I wanted to show the ABG. I wanted to show the ABG in the coming slide, sir.
Okay, coming slide. Okay, sorry. Yeah. So, what settings was this ABG done in? Can you please tell us?
Sir, I didn't hear you. Would you please come again, sir?
Sorry, you don't know the exact
ventilator setting, before doing this ABG.
ABG ventilator setting that was used for this ABG.
So we have used lung protective ventilator settings only, sir. We have taken 6 ml per predicted body weight of we have taken volume. It was volume control ventilation. 6 ml per kg tidal volume was taken. PEEP was taken around 10. Her PF ratios were around 134, sir. 135. We have kept her on a PEEP of 10. Respiratory rate was 28, sir. I'm sorry.
Okay, so the previous setting is what this ABG reflects, right?
Yes, sir. Yes, sir.
Okay, but you said persistent hypoxemia, PO2 of 62.
Sir, this ABG was before proning, sir.
No, this gas is before proning, right?
Yeah, before proning, sir. Yeah.
So my first question to you is how do you define hypoxia in an ARDS patient? What what target do you use as a marker for hypoxia in your patient?
Sir, PF ratio of less than 300 with a PEEP or a CPAP of more than 5, I would consider it as a hypoxia in ARDS patient.
So if I'm on FiO2 of 30% and my PaO2 is 65, you will call me hypoxic.
FiO2 30, 60, 200. Yes, sir, I would consider with like if you are required, if the patient is, I'm sorry, if my patient is requiring a PEEP, then I would consider it as a, no, it is a hypoxia only, sir. If requiring PEEP, then I would consider it as a hypoxia. Sorry, ARDS.
Just please go back to the previous slide. Okay, so if it's FiO2 of 50%, 10 of PEEP, PaO2 of 62, I will assume that the saturation is around 90 to 92, correct?
Yes, sir.
Okay, so first question is, how do you decide to paralyze somebody, and why would you paralyze this patient on 50% FiO2 and 10 of PEEP? What is the rationale for paralyzing this patient? You've done deep sedation, saturation is 92. Is saturation of 92 acceptable?
Sir, I would accept saturation of 92, sir.
So this patient,
my targets would be
ABG, you gave me saturation is close to 92. So
sir,
why would you paralyze this patient?
It was after muscle relaxation only, our saturation was 92, sir.
So what was the saturation before the muscle relaxation?
See, it was somewhere around 80, 85, sir.
80, 85. So how does paralytics improve saturation?
Sir, paralytics would it would improve the synchrony, sir. Like it would reduce the it would I mean there would be better synchrony, sir. If a better synchrony is there, there would be lesser ventilator-induced diaphragmatic dysfunction, lesser ventilator-induced lung injury, and lesser requirement of PEEP.
Dr. Mohan, based on the available evidence we have, what do you think would be the best option if a patient has a FiO2 of 50%, PO2 is 62, saturation is 85%,
and PEEP of 10?
And PEEP of 10. What do you think will be the best option in this situation?
Sir, I would deeply sedate only, sir. As of,
paralysis?
for the available evidence, according to the Rose study,
okay,
like paralysis, it has not shown to improve mortality.
No, Dr. Mohan, sorry. I think I don't know if Dr. Rajesh is also getting at the same point, but what are your options? Forget about paralysis, okay? Somebody's on these settings, respiratory rate of 28, FiO2 50, PEEP of 10, and saturation of 80 to 85%, okay? You have
Sir, I would see if the lung is still.
No, you have deeply sedated the patient. Okay. Now, what are your options? Just go through the list of options you can potentially do to improve oxygenation. Let's just list first and then see how to approach each of those steps. Okay. Just list all the options in front of you that you can do to improve oxygenation in this setting with this patient, correct, given the current data. Just go through all the options you have.
So I would make sure, since the patient is in shock, I would make sure the patient is adequately resuscitated. Vasopressors are continued. I would like to improve the
Don't worry about shock, just hypoxemia. We are talking about
hypoxemia. I would try to increase the PEEP, looking at the same time taking care of the plateau, keeping it less than 30. I would accept.
The first step would be to increase the PEEP, right?
Yes, sir.
How do you decide? How do you titrate PEEP in your ICU? For this patient, how would you titrate PEEP?
Sir, for this patient, I would titrate the PEEP I would look at the PEEP plateau and increase the PEEP, sir. If the PEEP plateau is increasing.
No, Mohan, let's not talk about hypothesis. You have a PEEP plateau of 28. You have a PEEP of 10. Let's talk about this patient. Okay, in this patient, how would you increase your PEEP? Let's talk about the first option before we go to paralytics. Okay, we'll go to paralytics when we exhaust all options.
I would make it 11, sir, and 11. Look at the saturations.
How long
would you? I would make sure the BP is not going down. I would look for the optimal PEEP, sir, where maximum recruitability will happen and minimal hemodynamic instability will be there.
So how do you look? How do you do that at the bedside? No, you said I look at optimal PEEP where maximal recruitment is happening. How do you do that in the bedside?
Bedside, I would look at the PEEP plateau, sir. I would make sure that it is not going more than 35. Like multiple methods are there, sir. Once ARDS net ARDSNet table will follow. Other thing, we'll look at the this pressure volume curve and look at the lower inflection point and upper inflection point. I would make sure that PEEP is between.
Tell us what practically you do at the
To do in the
bedside.
ICU, in your ICU.
Yeah. If you use a pressure volume curve and upper
No, sir. Like like what I
would.
would do is I would increase the PEEP and look at the saturation, sir.
How do you know if a patient is recruitable or not? No, you have increased the PEEP. Now, how would you say that, okay, this patient is recruitable? Is it the saturation you see?
Sir, I would see saturation and plateau, sir, P flat.
Okay, what would you expect if the patient is a recruitable patient? And if it is not, with the plateau pressure?
Driving pressure, I would see, sir, one thing. I would
So how do you
like to
calculate
keep
driving
it.
pressure? Can you please tell me? You said driving pressure, which is a good point. So how do you calculate driving pressure?
Driving pressure is tidal volume, ratio of tidal volume to static compliance, sir. So it comes as P plateau minus P. Studies by Amato et al. Has shown that the
No, don't know.
driving pressure,
This patient, what is the driving pressure now?
in this patient it is 18, sir.
18. Okay. So now, like Dr. Rajesh said, you'll increase the PEEP. Now, what will you observe? What should the driving pressure do if you recruit lungs?
Sir, if the lung is recruitable, driving pressure would ideally come down, sir.
Correct. So that is probably the best way, easiest way for you to clinically titrate PEEP, right? You titrate PEEP. As long as the driving pressure keeps coming down, you are recruiting more and more lung and you're doing good to the lung, right?
Yes,
If the
sir.
driving pressure doesn't change, then you are neither recruiting, probably you are recruiting and over distending. The driving pressure goes up, you're probably over distending, right? A simple way to look at it is look at the driving pressure change. So with every change in PEEP, maybe we'll go by increments of 2, increments of 3, whatever you think. 1 would be too little, maybe increments of 2. Most of us would say 12, 14, 16, and see what happens to the driving pressure. If the driving pressure keeps going down, that means you're recruiting the lung. Okay. So my first option in this patient would be to increase my PEEP and see whether I'm recruiting the lung and whether my oxygenation is improving. Correct?
Okay, sir.
Correct. Okay. So you've reached the maximum level of PEEP and you're still not reached your saturation target of 88. What do you do now?
Sir, I would see if there is if there is any asynchrony, sir.
Okay. So you're deeply sedated. There's no significant asynchrony.
Sir, I would think of prone ventilation. I would think of prone ventilation, sir.
The FiO2 to 50%, is it? Is that
I would increase the FiO2 to 0.6. 0.6, sir. Yeah. I would increase the FiO2, sir.
okay? What else?
I would increase the FiO2. I would increase the PEEP, keeping in mind the driving pressure and P plat.
So,
Sir, I would like to prone the patient, sir, if still not improving.
So after increasing PEEP, increasing FiO2, next option is prone ventilation, is it?
Yes, sir.
Is there anything else you would do?
so what mode is this patient on now?
Then volume control, sir. Control
Any
volume.
other mode that has been shown to maybe improve oxygenation better than volume control?
So, APRV has shown to improve, but if the patient is deeply sedated,
So between volume control and pressure control, which has a better oxygenation?
so there is no difference between volume control and pressure control in terms of oxygenation, but pressure control pressures would be more, but I mean volume may not be guaranteed, sir. It requires more intense monitoring by us. There is no difference, sir.
So what determines your oxygenation for any given FiO2 on a ventilated patient? So I have 2 patients on the same FiO2. What determines their oxygenation? Let's say same amount of lung disease. What ventilated parameter determines your oxygenation for any given FiO2?
PEEP, sir.
It's actually the mean airway pressure, right?
Yes,
The
sir.
higher the mean airway pressure, the better the oxygen.
Better is the oxygenation.
Now for the same settings between pressure control and volume control, which has a higher mean airway pressure?
So volume control would have, because higher flows can get better mean airway pressures.
let me ask you this question. At which phase of inspiration do you get the maximum alveolar pressure in volume control? Beginning of inspiration or end of inspiration? Where is the maximum alveolar pressure happening in volume control?
Maximum so it's at the
Alveolar pressure becomes maximum during initial part of the inspiration or at the last point of the inspiration in volume control?
at the sir at ending,
right? Because if I have to give 350 volume,
And
in
inspiration.
case you have only 10 ml, 20 ml, 30 ml, 50 ml, 100, 150, 200, 300, 350. Only when I reach 350, my alveolar pressure will be maximum, correct? And then immediately I go to expiration. So my alveolar pressure will drop, correct? Okay. Now in pressure control, when do you reach the maximum alveolar pressure? Initial inspiration or late inspiration?
PS above P.
Initial inspiration, right? You are delivering a pressure. So the moment the inspiratory valve opens, the pressure goes from peak to whatever pressure you have set, correct? The alveolar pressure is maximum at early inspiration and stays there till the cycling happens and then the expiration starts, correct? So the alveolar pressure is higher and longer during the entire inspiration during pressure control than volume control. Now, which will have a better mean airway pressure then?
Pressure control would be having, sir.
Yes.
Because immediately we are achieving.
Control should have a higher mean airway pressure for the same kind of tidal volumes that are delivered if set appropriately. So pressure control has better oxygenation. There is no mortality benefit. You're right. Studies have shown that pressure control improves oxygenation, but does not improve survival. So one thing you could try before you rush to paralyzing or proning is to optimize pressure control and see if the saturations are better. I'm just saying, I would just go step by step. I would not wait for 2 hours for each of the steps. I would probably do it one after the other to see, stand in the bedside and do one after the other to see where I can get better oxygenation. But first titrate PEEP, maybe switch over to pressure control. Then you say, is the patient still synchronous or not synchronous? Okay. All right. So I told you deep sedation, patient is reasonably synchronous. Would you still paralyze?
With deep, I would go with deep sedation only, sir. I wouldn't like to paralyze.
Is there any other mechanism paralysis can improve saturation?
Better synchrony, other thing, pressures will be better dissipated, sir.
Now, apart from synchrony, is there any other mechanism paralytics can improve oxygen saturation?
Particularly in this patient.
Just abdominal wall will be, abdominal muscle relaxation with abdominal wall will not be adding any, it will not add a pressure to the chest wall compliance, sir. We can paralyze the abdominal wall also, like
No, you're right. Just you have to phrase it a little better. So what I know you're trying to get to the answer. Dr. Rajesh gave you a clue. So what happens to the abdomen when you paralyze somebody?
We will not be using. Villi would be reduced, sir, because we are not using the abdominal wall is not being used. Better synchrony will happen and villi would be reduced, sir.
So in this patient, abdominal pressure is high, right? Paralyzing, what will happen to the abdominal pressure?
Sir, paralysis would reduce the abdominal wall compliance, sir. It would increase the compliance, it would reduce the pressure, sir.
Decrease the intra-abdominal pressure.
Yes, sir.
So the passive compression of the lung would get better?
Yes, sir, it would get better.
Would that recruit more alveoli?
Yes, sir. Basal collapse would reduce, sir.
Would that improve oxygenation?
Yes, sir. Yes, sir.
Is there any other mechanism you can think of? Anybody can answer. Poor guy, he's being targeted, but anybody can answer. He's being nice enough to present, so others can answer too.
Shivansh, I think.
Sir, I also know synchrony and abdominal wall compliance only, sir, for a muscle relaxant.
Sir, Cesar Trial has shown to improve, it has some anti-inflammatory activity also.
No, we're talking about improving oxygenation, right? Forget about all that. What happens to your oxygen consumption?
Oxygen consumption, it will decrease, sir, once because muscle relaxant.
Muscle, yes, sir.
Oxygen consumption decreases, right? So what will that do to your oxygen saturation?
It would improve, sir.
It will improve.
It would improve.
right? Because the venous blood going into the lung will have a higher saturation to start with, right?
Yes, sir.
So rather than making a 60% oxygenated blood to 80%, you can maybe make it 70% to 90%, correct?
Yes, sir.
Okay. So paralytics will improve oxygenation, 1 by improving synchrony, in this patient by decreasing abdominal pressure, and 3 by decreasing your oxygen consumption.
Now tell me about the evidence. You were talking about some studies. What are the studies we have and what did it show with respect to paralysis in ARDS patients?
Sir, we have accuracies and rose petal study, sir.
Okay.
Accuracy study, they have used, it was a randomized control study. They have compared cisatracurium with placebo. They have given cisatracurium of 37.5 milligram per, 15 milligram bolus followed by 37.5 milligram per hour. What they have observed that a better synchrony is achieved with in a cisatracurium group, which has translated into mortality benefit. Whereas in Roe study, there was no any mortality benefit, but it has also shown to increase cardiac events, more requirement of vasopressors and higher arrhythmia risk was present.
Why do you think in the accuracy studies there was a mortality benefit, but the most recent study?
So Roe study was underpowered. 270 patients were like somewhere around 300 patients were only taken, sir.
Okay.
And Roe study, I'm sorry, sir, that wasn't it. Roe study, sir, they were lightly sedated in the case. I mean, in the group, like they were lightly sedated, sir. Sedation was not proper in the case group. When the interventional group received about the petals, rose petals, sir.
Okay.
The interventional group, they received lesser sedation. It wasn't a deep sedation, sir.
Which is the interventional group? The one with the
Cisatracurium, sir.
Cisatracurium, they didn't give sedation. Are you sure?
Sedation was not appropriate.
They didn't give sedation, they give only paralysis.
No, sir, they have given sedation, but it wasn't to the level optimum. That's what RAS was only somewhere around 0 to -1.
In the group where cisatracurium is used. One of the criticism of the Roe study is that the sedation was light in the control group, not in the interventional group. You cannot give less sedation and give paralysis, isn't it? Even if you are given, probably you will not realize in terms of compliance, it may not make any difference. It's just that it will be a torture for the patient who will be awake but paralyzed. It was in the control group. The sedation was light sedation, whereas that was not the case in the accuracy trial. What was the other difference?
Underpowered, that's what I remember, sir.
Why it was underpowered?
Futility was achieved. That's
they stopped the study early, isn't it?
Yes, sir.
Whatever power calculations they had done, interim analysis, they found that it is futile, and they stopped. So it might, whatever evidence you have got may not be the complete result compared to if they had completed. Okay, so based on available evidence, do you think it is a good practice to use muscle relaxant in ARDS?
Sir, if the patient is deeply sedated and compliance is like P-plat is less than 30, with no much of asynchronous, I would continue with deep sedation only, sir.
Yes, I think only if there is a specific indication. For example, as you said, patient is there is no synchrony, or there is an increased abdominal pressure, or there is some other cause, increased oxygen consumption, and you want to reduce that, you would use muscle relaxant. If those indications are not there, you will not use the muscle relaxant. You will only aim for deep sedation. If you use cisatracurium, how long will you continue it for?
For 48 hours, I would like to continue, sir.
It's a very short term, isn't it? You
Short term, yes,
cannot give it forever. It is only going to be a maximum of 48 hours you will use. And in this particular patient, you told me that the patient had a FiO2 of 50%, and these settings will increase the PEEP and see if the patient is recruitable. And after that, you will increase the FiO2. After that, would you straight away go to prone ventilation, or would you use muscle relaxant?
Sir, sir, I would like. I would like to use muscle relaxants in view of probable poor abdominal compliance.
Yes.
I would try, sir.
Yes, I think most of the people will use muscle relaxant. If they are planning to prone patient, you would do all the other things, including changing the mode of ventilation. Maybe if required, even though there is no evidence, change the IE ratio. You will do all of that, deep sedation. Then you will paralyze the patient. Why would you paralyze a patient before proning?
Sir, before tube might get dislodged after proning, the patient moves, sir. Like we would make
you may have to reintubate, and you don't want to wait for the paralysis to start working before you reintubate, correct? That's one reason. What are the other reasons you would paralyze the patient first before prone ventilating?
Already, abdominal compliance is already poor. Other things, while proning, the chest wall and abdominal compliance might come down, sir.
Yes.
That is one more reason, sir.
And you want to reduce the work of breathing, whatever is there, isn't it? Especially patient is going to be prone. You have given enough sedation, but you don't want any use of respiratory muscles at all. So I would say that, I would definitely not go from, increasing FiO2 to prone ventilation. I would try all the other options first. In that, the last option is going to be muscle relaxation. Only after finishing muscle relaxation, I will go for prone ventilation.
Always stepwise.
Now tell me about the evidence for prone ventilation.
I want to say, what criteria do you use to prone in your ICU? Tell me an objective criteria you use to prone, or what criteria did the evidence use? You can, Dr. Rajesh asked you about evidence.
Sir, in our ICU, we after optimal setting of PEEP and FiO2, if still PF ratios remain less than 150, then we would consider proning, sir. If the patient is hemodynamically stable, unstable also, if there is no immediate cardiac arrest, we would prone, sir. Like PF ratios less than 150 after optimal ventilator settings, I would consider proning, sir. And other rescue measures like muscle relaxation and deep sedation.
So the evidence, right? So what evidence?
The Cesar trial has shown to improve mortality, sir. Proning done in early ARDS for more than 16 hours has shown to improve survival by more than it was more than 50%. 16. It was 16 in the interventional group and 32 in the control group, sir.
Which day mortality? Is it hospital mortality?
No, it's a 60-day mortality, sir. 28 day mortality. 28 days.
There was a 28-day mortality.
28-day mortality.
90 days.
So what criteria did Cesar use to prone?
Sir?
What criteria did Cesar trial use to prone?
Sir, they've used the PF ratios less than 150, sir, after 12 hours of optimal ventilatory settings.
So 60% FiO2 or higher with the PF ratio of less than 150, right? That is the criteria. So if somebody's on 30% and they have a PO2 of 75 with a saturation of 92, they may not have 150. I may still not prone them. So 60% FiO2 with the PF ratio less than 150 is what Cesar used. Okay. Is there any other circumstances you would prone apart from this criteria?
Apart from ARDS, sir?
Apart from PF ratio criteria, I told you 60% FiO2 or higher with a PF ratio of less than 150 is what Cesar used, and that's a very standard criteria that most of us would use in the bedside. Are there any other criteria that you would use now with new evidence around? Is there anything else that you would think of using?
Persistently high driving pressures.
Very good. Yeah. The PF ratio may be fine, but if the driving pressures are consistently high, I would prone them because maybe I can get down the driving pressure and decrease my ventilator-induced lung injury. So considering the current evidence that driving pressure is a single important parameter driving mortality, I would try to target the lowest driving pressure possible, right? So nobody knows what the magic number for driving pressure is, but we try to get it below 15. As low as possible, but even in this patient, the driving pressure is 18 right now. So with my PEEP titration, if the driving pressure doesn't come down and the saturation is worse, I will prone them. And sometimes the driving pressure is very high. I may have to prone them because the overall respiratory compliance may improve and my oxygenation may improve with lower driving pressures. Okay, that's other thing that I would look for. Okay. And what happens to your right ventricular function when you prone?
So RV function improves, sir.
Somebody's in severe carpulmonale and severe RV failure, I may consider proning. I'm not saying that's an indication, but I would just keep that in the back of the mind because that could be a rescue strategy for my RV failure if I struggle. So definitely FiO to 60%, PF ratio less than 150. The driving pressure is very high despite good oxygenation. I would like to prone, and as a salvage, experimentally as a salvage, because I know maybe my RV will improve. If somebody's in severe carpulmonale, which happens quite commonly in ARDS, I would think of proning as a way to improve their hemodynamics in those patients. So just keep that broad outlook in your mind. But in exams, I think if you quote Prosiva, most examiners would be happy. Keep going, please.
Severe respiratory acidosis also we can prone now, sir, in case good oxygenation.
Severe respiratory acidosis.
Absolutely. Yeah, bad respiratory acidosis, gas exchange very poor. Yes, you can.
Open lung with like open chest also, like pneumothorax with which says that P platelets are already high. Pneumomediastinum.
Is that an indication for prone ventilation?
So that would reduce the ventilator-induced lung injury hypoxia.
If there is a pneumothorax, what will be your treatment?
ICD, sir. ICD, intercostal tube, ventilator settings, I would reduce the tidal volume and increase the respiratory rate. I would try to keep the plateaus less than 30, sir.
I wouldn't say pneumothorax as an indication for prone ventilation, even pneumomediastinum. You would do whatever is the direct treatment for that, as you said, ICD. But you'll consider prone ventilation if this patient already has a ARDS, and on top of that, the patient has got now pneumothorax, and that has caused further deterioration in patient's gas exchange. You will do whatever is required for pneumothorax first, including either unilateral or bilateral, depending on where the pneumothorax is, and then you will increase your sedation. You will do all of that, but you have decompressed the pneumothorax, but compliance is still poor, and your CO2 is going up. Oxygenation is improved, but CO2 is still up. Because of poor compliance and rising CO2, I would do that because the patient has a background of ARDS, not because patient has got a pneumomediastinum or a pneumothorax. Prone ventilation is not a treatment for pneumothorax. Yeah.
So this is the X-ray of the patient before proning, sir. Severe ARDS. On day 9-10, patient 9 to 10 responded to prone ventilation, shock resolved and vasopressors weaned off. Day 11 to 13, hypoxia. She had another new onset hypoxia with shock and AKI. Ventilator settings were FiO of 0.6, tidal volume 350, PEEP of 12 and respiratory rate of 30, I ratio of 1:1.8. Plateaus we got was 30. She was prone ventilated, blood cultures were sent.
So what do you think has happened here?
Sir?
What has happened here? Why the patient has deteriorated again?
Sir, we are thinking of probably new onset sepsis, sir.
And where is the likely source this time, you think?
Even surgical source control also properly not happened.
Not happened. Other thing, maybe abdominal, she was not being fed, sir, from last 3-4 days. It could be translocation of abdominal bacteria, sepsis. It could be new onset HAP or a COTI or surgical site infection.
So your differential diagnosis is going to be more now compared to the initial episode of sepsis. That time it was limited, isn't it? It was mainly because you had a purulent vaginal discharge and abdominal distension. That time it was going to be mainly either vagina related or urinary tract related or abdomen related. Whereas now your differential diagnosis is going to be more, isn't it? Including hospital acquired pneumonia and your abdomen, and it's still the fistula might be still be causing problem. You have written later persisting mucopurulent discharge from the perineal wound, and your corti, CLAPSI, all those things will come into picture as well. Correct?
Yes, sir.
Okay.
Vasopressin, NORAD, vasopressin were started, CRT was started, plastic surgery reviewed in view of positive mucopurulent discharge from perineal wound, VAC therapy was initiated. Day 11 to 13 is IR team has reviewed in view of ultrasound abdomen and pelvis showing ecogenic free fluid in the pelvic cavity. Both diagnostic and therapeutic paracensis was done. In view of persisting shock, antibiotics were escalated to ceftazidime, avibactam, and aztreonam. Family were given an option of
Based on the treatment you have given, what was the likely source of sepsis you were treating, you think?
Sir, I was thinking of still perineal sepsis only, sir.
Okay. Perineal and intra-abdominal.
Intra-abdominal translocation.
Because there was a collection, you have put a drain, you have drained that as well.
Yes, sir. Family were given an option of ECMO in view of poor response to prone ventilation.
Just 1 second. Before you go to ECMO, is there anything else you can do to improve oxygenation after proning? Anything else you could do?
Sir, we have tried proning, sedation, muscle relaxation. Recruitment manuals we can try, sir.
Tell me what recruitment manuals you know of and how do you do it?
So recruitment manuals, one is sustained inflation, sir. We make sure the patient is euvolemic. There is no pneumothorax, and we'll keep the patient in pressure control. We'll make the PEEP 0. Pressure control will make it to 40 for 40 seconds. And in the meanwhile, we will monitor saturation and hypotension. If any time hypotension is happening, we would bring it back to the initial settings. And I will make sure the alarm settings are also, alarm settings are also like pressure setting is increased to 40.
Do you use this in your practice?
Sir, we don't, we regularly don't use it, sir.
Okay.
Like only when time accidental tube gets dislodged, not dislodged.
So if the treatment of the lung.
Yes, sir, ventilator getting disconnected or during suction, any desaturation happening, then sometimes we use it. If not, we don't really use it.
Oh, and why do you don't use it? Is there any evidence for that? What is the recent study? What did it show?
So, ART trial has shown to, ART trial has shown to worsen the ventilator-induced lung injury, sir.
Okay, worsen what? Sorry, worsen the lung injury. And
Lung injury.
What else did the ART study show?
Hemodynamic instability. Like, I'm sorry, sir, I don't remember.
There was hemodynamic instability, isn't it?
Instability,
Higher incidence of cardiac arrest.
Correct.
In the group where the recruitment maneuver was done. So it might improve oxygenation, but it might cause more hemodynamic instability. So it is not a recruitment maneuver I would do in my practice on a routine basis or even occasional basis. What are the other recruitment you can do? One you have spoken already, correct? Stepwise increase in PEEP you will cause. That's also recruitment. This is another one.
So there is no definite evidence for steroids, sir.
Steroid
We don't use, sir. Only if we are thinking of some fungal pneumonia ideas, PJP pneumonia ideas. Or,
no, we're talking about recruitment. Is steroid used for recruitment?
No, sir. No, sir. No, sir. I'm talking about other rescue strategies, sir. Recruitment manual, other is a stepwise increasing, sir.
Okay.
We will taking into account of driving pressures and plateau pressures, keeping into in the normal range. I would stepwise increase the plateau from PEEP from 8 to 10. I will again take the patient on pressure control. I would initially start with 8 or 10. I would slowly increase from 2, where the compliance decrease, where the static, PEEP plateau increases. I would reduce the PEEP by 2, sir, and I'll keep it at that level, where the maximum recruitability would probably happen.
Okay. And what is the evidence for that?
So evidence remains the same for all recruitment manuals, sir.
Yeah, what is that?
Low study, I think, sir.
Yeah. What does it show?
No study has shown any mortality benefits, sir.
Yeah, but what does it show? It doesn't show any mortality benefit, but there is some benefit, isn't it? What is that benefit? Most of these studies have shown. It improves oxygenation. Right? What is low study? What concept? They use some concept in low study, correct? What was that concept? You already mentioned it.
So they have a sustained inflation has shown to reduce atelectotrauma, sir, cyclical atelectotrauma.
Okay.
High.
Now, what is the Shivansh? Would you be able to tell what is the low study? What did it look into, and what was the outcome?
Low study, no, sir.
They looked into open lung strategy, correct? What is open lung strategy? Dr. Mohan?
Open lung strategy is low tidal volume with keeping a high PEEP to prevent atelectasis during expiration, sir. To keep the lung open during expiration, even during expiration, because due to lack of surfactant, reduced surfactant, there is a very high chance of ARDS lungs to get collapse. So they have kept a high PEEP, sir. During end expiration also, they kept it open. That alveoli, they kept it.
So one group had low tidal volume and low PEEP. Another group had low tidal volume and high PEEP. And the low tidal volume and high PEEP is what open lung strategy is called. Was there any benefit with that?
Oxygenation was better with high tidal volume, high PEEP and low tidal volume.
Okay.
But it has not shown any mortality survival benefits.
So the recruitment manual is one you would consider. What are the other things you would consider before going for ECMO?
For improve oxygenation, inhale nitric oxide therapy, you can consider.
Okay. So what is the evidence for that?
How does it work and what is the evidence?
But by inhale nitric oxide, it will increase pulmonary vasodilation, sir. So decrease the pulmonary vascular resistance. So improve the perfusion. Ventilation perfusion match, it will improve, sir. So improve oxygenation. Then evidence-wise, no mortality benefits, sir. Only improved oxygenation. Right, sir. For this is also for a short time, sir. It will not stay for a long time. Then
So,
even
you are right, but what the way you need to explain is it's the alveoli which are ventilated, the nitric oxide is going to go more, and the blood vessels that are going to those alveoli will get dilated more, right?
Sir.
If the alveoli is collapsed, nitric oxide will not go there, so that blood vessel will not be dilated as much. Versus the alveoli that is reasonably ventilated and open, nitric oxide will go, and then that blood vessel will get dilated. So there is a better ventilation, perfusion matching that are happening. Okay, so think of it like vascular recruitment, right? You're recruiting the alveoli. Here you're recruiting the blood vessels that are going to the alveoli that are recruited, right? So for nitric oxide to work, you need enough alveoli that are recruited. If most of the alveoli are collapsed, nitric oxide is not going to work. So you need to make sure that you are adequately recruited the alveoli first by all the maneuvers Dr. Rajesh had told you earlier, and then you can give a trial of nitric oxide before you jump into ECMO.
Is there anything else you would do, Dr. Mohan, apart from nitric oxide?
Sir, I would think of giving steroids, sir.
Okay.
Like,
you think steroid will immediately improve the oxygenation?
No, sir. No, sir.
Can I ask you a question here? This patient has got a Candida tropicalis in the blood on TPN, several surgeries, day 13 of ARDS. Would you consider steroids in this patient?
Not really.
What is
sir,
the
like,
evidence on steroids in ARDS? Do you know of any studies that have looked at steroids in ARDS?
Sir, Meduri trial, it has not shown any mortality benefit. But DEXA-ARDS latest, it has shown that in patients with early ARDS, in the early exudative proliferative phase, if dexamethasone is given, it has shown to have some anti-inflammatory activity and improve mortality, sir. But it was in early ARDS, sir.
So not only did they show that, they showed that if you give it after 14 days, there is increase in
Muscle,
increase in mortality, right?
mortality and neuromuscular.
Increase in mortality. This patient is almost day 14 now. So this is too late now to give steroids. It will increase mortality. On top of it, she's a host waiting to get bad infection. So probably the risk benefit of steroids in this patient would sway me away from steroids. For the purpose of ARDS, I would not do it. Any other strategies, Dr. Rajesh Shastri?
Sir, HFOV, like, but we haven't used any time.
What's that? HFOV. Would you use HFOV?
We have never used it, sir.
Okay. But if I give you the high frequency ventilator now, would you use it on this patient?
Like oscillate trial has shown to worsen mortality, so I won't use it. But I was just looking at the rescue strategies.
I would now just my advice for the exam. There may be if they ask you what are the different options are there, I would maybe use high frequency and ventilation as one of the options. But that will be one of the last options because you're not going to use it, isn't it? And there are studies which have shown that it is not beneficial. Whereas if I ask you, what are you going to do in this particular patient? I would only talk about the options I normally use in my practice. Operation is not something I use in my practice, isn't it? Most of the
I would
now. So,
sir, I would continue lung productive ventilation. If possible, prone ventilation is possible. I would reprone the patient. I would make sure the volume status, she's not going into fluid overload.
Okay, tell me about the volume status.
So volume status, this patient actually I haven't shown, but she was a little positive, sir.
Okay. So is there any evidence about the volume status and outcomes in ARDS?
Yes, sir. There are observational studies which have shown that like 1 liter per day by the 7th day, if it is like if 1 liter per day by the 7th day, if it is positive, it has shown to increase mortality, hospital mortality, ICU mortality, and increase the ventilator. Ventilator days.
Okay, yeah, that is with the observational studies.
It was an observation study.
In your practice based on observational studies?
Fact trial has shown they have compared conservative versus liberal strategies, sir.
Okay.
They have, there was no mortality benefit, but it has shown to.
So how did they aim for conservative strategy, and what did they do in the liberal fluid strategy? How did they monitor the patient?
They were looking at the CVP and pulmonary artery pressure, sir.
Okay.
Like in the liberal strategy, they kept it less than 12.
Hmm.
Conservative, in liberal strategy, conservative, they kept it in less than 12.
12 of CVP or what is it?
12 centimeters of CVP, sir.
No, that's not correct. Anyway, again, I think all these trials, you need to read them, and you need to know them very well. Okay, it was not 12; it was 4. It was more than 12 and less than 4.
More than 12, less than 4, sir.
Okay. So, and what did they find? Were they able to achieve these targets in that study? They were not able to achieve. In most of the patients, they were not able to keep the CVP less than 4 or more than 12. It was the same with pulmonary capillary wedge pressure as well. They had those targets, but most of the time they were not able to achieve. But what did they achieve in that study?
So they have achieved, volumes they have achieved, sir. Fluid,
Yeah.
fluid
The volume
volume.
targets they were able to achieve. There was a clear difference between the restrictive fluid strategy and the liberal fluid strategy,
Liberal fluid.
isn't it? And what was the outcome?
So there was no difference in mortality,
Okay.
but extrapulmonary organ dysfunctions were less in liberal, conservative strategies, restrictive fluid volume strategies.
Okay. So in ARDS patient, what will be your normal strategy with regard to fluids? This patient is fluid overloaded anyway. So I think you would.
So if the patient is immediately in shock, I would follow the surviving sepsis guidelines, sir.
Okay.
In the initial phase, resuscitation phase, I would give fluid, sir.
Okay. After the resuscitation phase is completed, how would you manage?
I would, sir, I would see if the patient is hemodynamically stable for at least 12 to 24 hours, I would think of diuresis, sir. I would continue diuresis if creatinine is not increasing. I would consider ultrafiltrate removal also, sir.
So if a patient is not responding to your diuresis, you would consider dialysis as well and remove ultrafiltrate.
Yes, sir.
So you aim for a negative fluid balance. Once the shock phase is over, and now and there is no other risk of end organ damage like your acute kidney injury and other things. Okay. Now tell me about high frequency oscillation. What are the studies done, and what did they show?
Oscillate and Oscar trial they have done, sir. Oscillate was a negative trial. It has shown to increase mortality.
Okay.
In patients using HFOV.
Okay.
Oscar, it has not shown any mortality benefits, sir.
Okay.
But at the same time, there was no worsening in, that's what I.
Again, I think you need to read these studies and know about them. Which was the study which was stopped early?
Oscillate was stopped early because of high mortality, sir.
Yes. There was no benefit and there was possible harm. So that's why they stopped the study. Okay. Dr. Ramesh, do you have any other questions at this stage?
No, I think we can keep going forward. I think we've covered most of the ARDS
Yes.
studies.
Thank you. Please go ahead.
So day 14, hypoxia was persisting and shock was present. Organ supports were continued. Surgical gastroenterology reviewed. Re-exploratory laparotomy with pelvic collection evacuation was done. Peritoneal fluid culture was suggestive of carcinoma resistant Klebsiella pneumoniae. She was continued on ceftazidime avibactam with STNM. She was reprone in view of persistent hypoxia. Ventilator settings were 0.8 FiO2, tidal volume of 325, PEEP of 12, respiratory rate of 35, IE ratio of 1:1.8, and plateau of 40. So this was the ABG, sir. Day 15. pH of 7.04, PCO2 of 85, PO2 of 65, FiO2 of 0.9, bicarb 22, basics of -8, and lactates of 1.2.
So what is the summary of this ABG? What would you say?
So ABG patient is having both respiratory and metabolic stresses, sir. Expected bicarb for PCO2 of 85 would be around 28 to 30, sir. It is still 22, and base steps it is more than -2. It is -8. She is having both respiratory and metabolic stresses, probably.
And hypoxia and hypercapnia.
And hypoxia and hypercarbia.
Okay, fine. Go ahead.
On day 15, VV ECMO was initiated. Ecmo Settings were blood flow of 4.6 liters per minute, RPM of 2,700 per minute, sweep gas flow of 6 liters per minute, and ECMO FiO2 of 1.
What is your indication for initiating ECMO?
Sir, in this patient, it was difficult to oxygenate or difficult to ventilate, sir. PF ratios were consistently being less than 80. And PCO2 was also high, more than 60 with the pH of less than 7.2. That's the reason we thought of ECMO.
What are the preconditions?
also high, sir.
Plateau pressures were also high.
Pressure was high. It was 40. isn't it? So
40.
that can be one of the indications. So what are the preconditions for ECMO?
What, sir? I'm sorry, sir.
Precondition, what sort of diseases would you consider ECMO?
The ECMO respiratory diseases like severe ARDS, pH, PF ratio of less than 80 for 6 hours or less than 50 for 3 hours, or pH of less than 7.24 with PCO2 of more than 65, or a patient awaiting transplant as a bridge to transplant in patients.
I would say that there should be a good chance of reversibility, or there should be a end destination like bridge to transplant or something like that. If it is not, then I wouldn't subject a patient to ECMO, because it will be bridge to nowhere. You will end up with a disappointment. Is there any score you will use?
Moral score.
Like reserve score.
What is score and what should be the score?
So Murray score more than 3, we would consider ECMO, sir.
Fine. And this patient score, how much was it?
Sir?
This patient's score, how much was the score, Murray score for this patient?
Murray score, we
anyway,
haven't calculated, sir. It could be.
That's fine. Now go to the next line. Again, I don't think in your exam they will ask you this question, but you have given all these numbers, blood flow, RPM, sweep gas flow, FiO2. How do you decide how much to set?
How much to?
No, how much flow you should be having, how much
like
sweep
50.
flow you should be having, how much FiO2 you should be having. How do you decide?
Sir, like I would like 50 to 60 ml per kg blood flow. I would per minute blood flow. I would target, sir.
Okay.
With I would target saturations of 85 and P plateau of less than 25. Accordingly, like sweep gas, I would start with the higher sweep gas, sir, and FiO2 of 1.
So plateau pressure for the sweep gas flow, you look for plateau pressure, is it?
No, sir. Like in ultra low tidal volume ventilation, I'm talking about.
There are two things actually here, isn't it? One is setting of the ECMO itself. Another one is setting of the ventilator. So with the ventilator, you are going to have a ultra low volume protective ventilation you want to do. So you will have a low tidal volume and probably low FiO2 and slightly higher PEEP to keep the lung open and keep the plateau pressure low. Otherwise, there is no benefit of having ECMO, isn't it? If you're not going to protect the lung, there is no point having ECMO at all. So that is a priority. What about ECMO settings itself? How do you decide?
ECMO settings, I would target a blood flow of 50 to 60 ml per kg per minute. Sweep, I would start with FiO2 of 1 and sweep gas flow of 8 to 10 liters per minute. Sir.
So basically 2/3 of the cardiac output is what you would look for blood flow, and 1 to 2 times your sweep gas flow, the blood flow is what going to be sweep gas flow. Okay, I don't think they will ask you in the exam. How do you titrate further? How do you titrate your sweep gas flow?
Sir, according to PCO2 and PO2, sir.
Okay, if the PCO2 is high, what do you do with the sweep gas flow?
I would increase the sweep gas flow, sir.
If the PCO2 is low, what do you do with the sweep gas flow?
I would come down on sweep gas flow, sir. I would come down on sweep gas flow.
Okay. And what is the evidence for ECMO?
Evidence, Cesar Trial and earlier trial have come, sir. Cesar Trial has shown to have mortality benefit.
Okay.
Earlier trial also would have got mortality benefit, but it was underpowered and there was a lot of crossover, sir.
So first tell me, what did they do in Cesar Trial? And what was
Cesar Trial? They have taken patients who were difficult to oxygenate and ventilate. They have taken the inclusion criteria of this Murray score of more than 3 or PF or ventilated for less than 7 days with constantly high P plat of less than more than 30. They have included these patients, sir.
Okay.
And they have and they were referred to special centers in England for ECMO. And they have compared ECMO with conventional mechanical ventilation. They found that ECMO patients on ECMO had a mortality benefit.
How much was it?
It was almost 15% more, sir. 15%.
Yeah, it's a 63% versus 47. What was now? Where were the patients in the control group, and where were the patients in the treatment group? Were they in the same hospital?
The treatment group, they sent to a special ECMO center, sir. I don't exactly. There were 6 ECMO centers. They were sent to.
Yeah, it was sent to Leicester, the specialist center. What about the control group patients? Where were they?
They were in their parent centers. Wherever they were admitted, they were in the same centers, sir.
Okay. And what was the outcome?
So outcome was better in the ECMO group,
Yeah.
but the fallacy was in control group. Lung protective ventilation was not properly followed.
It was not standard, isn't
Standardized.
it? Lots of different hospitals, and practice was variable in all those different hospitals. It was not the same. And what other fallacies?
Sir, validity maybe they've sent it to special centers.
And did all the patients who went to the ECMO center had ECMO?
No, sir. 30%.
No, sir,
Yeah.
they died.
That was another issue. The overall result of the study is that on the basis of intention to treat analysis, all the patients who were sent to ECMO centers had a better survival benefit compared to those who were not sent. Having said that, one was the control group was all different. They call it a district general hospitals with a variable quality and variable treatment protocol. And the patients who went to the treatment group didn't receive the treatment as well. So it may be not the ECMO itself, it may be the treatment in that specialist center, which may be better. So that is the major criticism of the paper. Now, even though it showed a survival benefit, how much you want to believe in that, how much you want to change your practice, it is little difficult to comment. What about your study?
Sir, EOLA study, they have compared the intervention group. They have received ECMO, and the control group was conventional mechanical ventilation.
Okay.
Severe ARDS patients were recruited.
Okay.
The inclusion criteria was a PF of less than 50 for 3 hours, or PF of less than 80 for 6 hours,
Okay.
or pH of less than 7.25 with a PCO2 of more than 60. And patients were, it was they've initiated VV ECMO, and they've considered this in patients with reversible lung disease. They have compared, they did not find any mortality benefit, but fallacy was there was a lot of crossover from control to interventional group.
Again, your statement that there was no survival benefit is wrong. There was a survival benefit. There was a difference. Statistically not significant. It was a difference, but p-value was not significant. That was the problem. And other thing was there was a crossover. What type of crossover was it? The patients in the treatment control group, some of them came to the treatment group.
Control to treatment, yes, sir.
Yeah, and what happened to those patients who crossed over?
So they would have also,
all of them survived. All those patients were not supposed to have a ECMO. There were 15 of those. All of them, received ECMO and they survived. So, what is the overall conclusion of these two studies? Was there any systematic review, meta-analysis? What do the experts believe, based on these two studies?
So we have to consider ECMO, sir.
Yeah.
In patients,
there was a survival benefit in the meta-analysis, which included both Cesar trial and UOLI trial. And and overall conclusion is that most likely there is a benefit by using ECMO. And I know there is more evidence now after COVID as well, where we have seen a lot of survivors after COVID as well. Even though COVID itself, those required ventilation, overall mortality was very high, but there was a significant mortality benefit in those as well. So based on these two studies, they believe that at least ECMO doesn't cause harm. If anything, mortality was the same in ECMO group compared to the non-ECMO group. And because there was a crossover and those patients survived, there may be possibly there is a benefit. We will be waiting for more studies to come. But would you consider ECMO in all patients?
Sir, I would consider patients in ECMO if I consider the disease is reversible.
Yes.
If it is futile, I wouldn't consider, sir.
That's fine. But if it is a reversible condition, would you consider ECMO in all patients?
Yes, sir. It is a rescue therapy. Other
Therapy, you would consider it only in moderate to severe ARDS. After all the other options have been exhausted. You wouldn't use it as one of your earlier options. It has to be a severe ARDS. It has to be after, preferably, you have tried prone ventilation and patient has failed prone ventilation. Only after that you will consider, not before that, because there is some evidence that ECMO is beneficial, but the evidence is not very strong. Having said that, we still believe that ECMO is helpful. So you would still consider it, but only after all the other options have failed and patient is going to die anyway, if you don't do it. So those are the patients where I will consider ECMO. Okay. Do you think it was appropriate to consider ECMO in this patient?
Yes, sir. I would think it's appropriate to consider ECMO in this patient.
What is one of the contraindications for ECMO?
Coagulopathy. It is not a absolute contraindication, but it was present initially, sir. Now it isn't.
What are the other contraindications?
Contraindication immediately after surgery I initiated, sir. Surgery 14th it was done for because absolute contraindication of ECMO is one of these.
After 6 hours, we can initiate. After 6 hours of surgery, we can initiate.
After 6 hours of surgery, you can. Okay, that's fine. What are the other contraindication?
Multi-organ failure, sir.
Multi-organ failure is not a contraindication actually. Now, unless you think the multi-organ failure has progressed so much.
In this patient, I'm not sure whether you have even achieved good adequate surgical source control. There has been several procedures done for the same problem for over almost month.
Actually, it was difficult to achieve source control, sir. Actually,
so if you put her on ECMO, you're going to limit your options of doing further surgical clearance of whatever if something comes. So without clearing the surgical source, I'm not sure the lung is going to get better in her, because looks like the ARDS is predominantly related to the persistent vaginocutaneous rectal fistula.
Actually, that was the reason we have taken for surgery just before putting her in ECMO.
So, but every surgery, none of the surgeries have been curative so far, right? You've gone there, drained something, come back, and then it's recurrent. I am not convinced that adequate source control has been done. And as long as that is not done, the lung may not get better. So that is something that I would strongly think before putting her on ECMO, because you've not been successful to do any of this for a while, right? It's a very complicated case. You may never get a good source control.
And what about the length of ventilation? Is there any relationship between the length of ventilation and outcomes with ECMO?
They have shown, initial studies have shown, if the length of ventilation is more than 7 to 10 days, the ECMO outcomes are not good. But recent studies that has become a very relative contraindication, sir.
Okay. How long was this patient on ventilator before the patient was put on ECMO?
14 days, sir.
14 days. On the whole, maybe this patient has survived. That's why you were presented. But I wouldn't have considered, ECMO in this patient, as Dr. Ramesh said. It is persistent sepsis. That was the reason patient is still in hospital or ICU even after day 15, isn't it? And the source control you were not able to achieve. The primary disease doesn't look at this stage that it was going to be reversible. And the patient was on ventilator for a long time as well. Overall outcome, usually, you would expect to be negative in this case. And usually most of the people wouldn't have considered ECMO, I think. I don't know, maybe this patient was very young, I think, isn't it? Otherwise, she was very well maintained, I suppose, and family were very keen. Maybe there were lots of other factors which were going in as well, I suppose. That's why you might have considered ECMO. But what do you say, Dr. Ramesh?
I agree. I also would probably have stayed away from ECMO, but probably because of other reasons, young family pressure, they would have put. But like I said, without source control, I don't see this patient getting better and going home. And even if she comes off ECMO, it's just going to be back to square one. Go home and come back for another admission with sepsis and septic shock. So her survival in the next 1 year is abysmal. So I may be able to save her of this hospital admission, but I'm going to bring her back to the hospital within the next 1 year. The mortality is going to be extremely high. So probably I would have kept away from ECMO in this patient too, for those reasons, like you said. can we just stop here? I think we've covered a lot of ARDS and ECMO. Is that okay, or do you have anything more to discuss, Dr. Mohan?
This must be the last slide, I think. Correct, Dr. Mohan?
I'm sorry, sir. Acidic fluid has shown Klebsiella pneumonia.
Okay.
Same, sir. Last slide, sir.
Okay. After that?
After that, still she's on ECMO, sir, day 16 to 22. This were the ECMO settings. VV ECMO, blood flow of 4.5 liters per minute, RPM of 3,500, sweep plus of 5 liters per minute, FiO2 of 0.8, tidal volume 150, FiO2 of 0.3, PEEP of 8, and plateau of 22. Shock improved, vasopressors were weaned off. Blood culture showed carcinoma and position-resistant Klebsiella pneumonia. Dual carcinoma and phosphomycin was initiated. Intermittent CRT was initiated in view of AK. So this was the actually her oxygenation is improving, sir.
But on 80% oxygen, isn't it?
She's on 80, sir.
Yeah, on ECMO.
Here it is 80, sir. Yeah.
Oh, yeah. On here 100%.
And
That's it, isn't it? Any other slides you have?
nothing, sir.
That's it.
Still on ECMO, that patient?
Yes, sir.
Hey,
I think exhaustively you covered almost every paper. No, Dr. Rajesh has covered every paper in ARDS that you need to know. But at least note down the names and go back and check it out. The easiest way to do it would be if you go to criticalcarereviews.com. They have section-wise list of all the important articles. So it may be a good place to start so that you know all the links are there. Then you can get the names out of there and then go back and read them in bottom line or any one of those websites, which gives you a good summary. So, but I think all these papers are something that all exam goers should know. At least you should be able to know the abstract and be able to say what the study looked at and what outcomes they did.
On the whole, good performance, Dr. Mohan. We were a little tough. I don't think your real exams you will have so much tough questions.
That's unfair to you because you take all the questions. No, the other 134 people kept quiet. So,
yeah, I think it was a very extensive and elaborative discussion on this topic. I think most of the areas were covered. To initiate with a case, most of us initially feel a case comes with ARDS, the discussion will only focus, but the beginning can be anything, the differentials comes and all that. So I thank both of you, sir, Ramesh sir and Dr. Rajesh in bringing this discussion. And I thank both Mohan and Sivanya to be a part of this presentation. And I thank all the audience. Now also after around close to 2 hours, we have more than 150 odd audiences still hanging around. So it reaches to more than 2,000 students by a day or so, sir. So we are hopeful it will be useful for the students and many more programs to come.
thank you
both
so
of
much.
you.
Good luck to both of you for the exams.
Thank you, sir.
All the best.
And,
Thank you.
thank you, Dr.
Thank you,
Rajesh.
Raman. Thanks, Dr.
Thank you,
Rajesh.
sir.
Bye.
All the best, Mohan and Himanshu.
Thank you, sir.
Thank you, sir.
Thank you.